All right, well, in the interest of time, I'll go ahead and get started so you guys can get back to your patients. So thanks for joining us today for our Thursday Lunch and Learn session. This is, I think, the third one that we're doing. So for those that don't know me, my name is Rochelle Dumm. I'm a certified prosthetist orthotist with Dankmeyer. I've been here for about 3 years, and I work primarily out of our Linthicum location, but I also collaborate with physical therapists at Kennedy Krieger and Johns Hopkins, seeing both pediatric and adult patients. Today, I will be talking about reciprocating gait orthoses for individuals with spinal cord injury. So first, I'll discuss who would be an optimal candidate for an RGO and what are some of the contraindications for the device. Then we'll go over the timeline from physical therapy before the RGO all the way through delivery, follow-up, and annual maintenance. And then lastly, I'll review some goal setting for patients, as well as managing patient expectations about the RGO. Feel free to stop and ask questions along the way. Feel free to unmute or type something in the chat. We have Angie and Amy here helping to monitor the chat room.
Okay.
All right. So first section, ruling in the RGO as an option. Okay. There we go. So for those that don't know about RGOs, RGO stands for Reciprocating Gait Orthoses or Reciprocal Gait Orthosis. The purpose of an RGO is to allow an individual without active lower extremity motion to produce a reciprocal gait pattern. They're primarily used for individuals with spinal cord injury, traumatic or non-traumatic. And an RGO is a completely mechanical device. So there's no motor, there's no battery, no power. And the device is operated simply by weight shifting and using the mechanics of the device to operate it. So an RGO can help someone to stand upright with or without an assisted device for therapeutic standing or ADLs within their home. They're mostly for therapeutic ambulation, although there have been some reports on patients that have used them in a more functional capacity, but for mostly they're for therapeutic ambulation. The way an RGO works is that by shifting weight to one side and leaning the trunk back, you're able to flex the contralateral hip to produce a reciprocal gait pattern, as you can see in the video here. All right. So in general terms, an RGO is comprised of bilateral KFOs, then hip joints that can be locked in extension or unlocked for sitting, a reciprocal mechanism, which is really what sets an RGO apart from other devices, and then a pelvic or a spinal section to which the reciprocal mechanism is attached. RGOs are really complex devices. There are lots of different ways to build them. Not all of them look like this RGO in the picture, but in general, this is kind of what they're comprised of. So in orthoses, we name everything by the joint or body segment that they cover. So technically, it's actually a TLSO HKFO because it covers the thoracic spine all the way down to the feet. But we call them RGOs. It's a lot easier. RGOs can be constructed in many different ways. So if you're more interested in the componentry side of things, how we actually select different device design and that sort of thing, that's kind of outside of the scope of this talk, but I'd be happy to do a targeted section on componentry selection. So reciprocating gait orthoses are very complex devices. They're very bulky and heavy. They take up a lot of space. They're hard to transport. They do require a lot of training to use. They're not very intuitive devices. Patients usually require assistance when they're trying to don and doff the devices. And often the most frustrating part is that they take a really long time to make and fit. But for the right person, an RGO is definitely worth the wait. When we're evaluating patients for a device as complex as an RGO, it's really helpful to work in a multidisciplinary environment. That way, we're involving the physical therapist, orthopedics, neurology, whoever is necessary for that patient's full scope of care. Having the patient support system present is also important so that they're part of the decision-making process and they can see what is required to help the patient be as successful as they can be. It also helps the support system appreciate how much work the patient is putting into their care and their rehabilitation. So the interdisciplinary team approach is really optimal for helping to coordinate a care plan for the patient, figuring out if there are other disciplines that need to be brought into their treatment plan, as well as discussing their pre-RGO therapy, as well as setting goals with the patient, their goals for physical therapy and once they go home. And of course, managing the device over time, making sure that the therapist and the patient are on the same page, as well as involving orthotics as indicated. So we participate in a number of multidisciplinary clinics in many aspects of care, not just for RGO management, but for prosthetics and many orthotics clinics as well. And we really do appreciate the communication with the physical therapists that we work with so that our patients mutually can have the best outcomes possible. We want to make sure they get the most out of their sessions with you all as they do with the devices that we're providing them. Okay, so what are we actually looking for when we're assessing a patient for an RGO? From a physical assessment standpoint, range of motion is really important. By textbook standards, contractures over 30 degrees at the contractures of over 30 degrees at the knee and ankle are usually just strict contraindications for an RGO. While technically contractures over 10 degrees can also be accommodated in an RGO, it's really difficult to do so. And they really do change the weight line from the hip to the floor. So they can be much more challenging to accommodate. So it's really best to have as much range of motion as possible before starting the process. Likewise, less than 5 degrees of passive hip extension makes it difficult to actually produce a reciprocal step in the RGO. That being said, there are ways to align the hip joints in space so that you are able to get more than 5 degrees of hip extension or functional hip extension in the device based on how you align those hip joints in space. So worth considering, but the more passive hip extension you have, the better chance you have of actually producing a full reciprocal step with the RGO. Spasticity is not necessarily a contraindication for an RGO, but usually individuals with lower spasticity or well-managed spasticity tend to have better outcomes. It mostly depends on how much the spasticity affects their ability to actually come to a full standing position and engage the hip joints in standing, or how much the spasticity affects their ability to don and doff the orthosis appropriately. Definitely a case-by-case basis, but it's worth considering. All right. Continuing on with physical assessment, individuals must have a good upper body strength as they have to pull to stand with the orthosis on. There's no powered mechanism. It's, like I said, it's a completely passive device. So there's nothing that's actually going to power them from a sit to stand transition. There's nothing that powers the knee joints into extension or powers the hip joints into extension like an exoskeleton. The hip joints are solely locked by shifting the weight line posterior to the hip joints, and then actually thrusting the hip joints into extension to lock them. There are also some weight restrictions on certain RGO components, in particular the reciprocal mechanism in the posterior. There are some weight limits for that, as well as the hip joints. In general, there isn't really a height limit for the device per se, but it definitely impacts what type of components we select, what type of materials, that sort of thing. In general, patients over 265 pounds require extra consideration. Not to say we can't do it, but we have to pick different materials and talk with the fabricator ahead of time. All right. So functional assessment. I always evaluate patients in a clinic setting. So with the physical therapist present, usually somebody from the patient's family is also present, which is helpful. but I always have the physical therapist perform the functional test because you all are much more well-versed in what the patient's capacity is. You've been working with the patient presumably for a longer period of time, and we can do this assessment together. Usually I can stand and look at views from the different planes to see what kind of control is necessary. I'm looking at ankle alignment, knee alignment, everything while the physical therapist is assessing the strength at the glutes to see if they're able to actively control their hip extension. So usually during a standing assessment like this with the knees blocked, we're looking at how much pelvic support is required for a patient to control their hips in the sagittal plane. If they're able to actively extend and activate their glutes without pelvic support, they may or may not require an RGO. There's some other things that we need to consider, but we're also looking at trunk alignment at this point. So if they exhibit excessive lumbar lordosis to compensate for lack of glute strength, maybe it's something where an RGO could be beneficial to promote glute extension so that they don't have to compensate as much with their lumbar spine. Next part of functional assessment is actually attempting to take some steps. So we're looking at limb advancement, either with prefabricated KFOs that are locked. So we're eliminating the knee and the ankle. In this assessment, we're really just looking at the hips and proximal. Or if you don't have locked KFOs, you can use knee immobilizers with a solid ankle AFO or something similar, just to focus as much as you can on the hip motion. So if someone is able to control their sagittal plane hip alignment and can actually initiate a step on their own, they probably don't need an RGO. It will probably be too much orthotic control for them. But on the other hand, if they have difficulty maintaining that hip alignment in the sagittal plane, they're unable to initiate a step on their own without assistance, an RGO will likely be beneficial to them, depending on what their other goals are. So this is kind of a crazy busy slide. I will walk you through it. And this is just my decision making when I'm evaluating patients for an RGO. By no means is this a completely exhaustive list or a process that you must go through. Everybody has their own way of evaluating patients and making their own decisions. But this is kind of my thought process, and I'm open to any questions or comments on as we go through this. But the first two big things that we look at are the range of motion and spasticity. So if they have those big contractures, or you think that you can reduce the contracture, we definitely recommend doing that before evaluating for the RGO, or at least thinking about that while we're evaluating the patient. Like I said before, contractures over 30 degrees are definitely contraindicated for the RGO. Same thing with the passive hip extension of at least 5 degrees. If they don't have it yet, maybe think about managing the range of motion first, and then reconsidering an RGO in the future. And then with spasticity, not necessarily a contraindication, just depends on how well controlled it can be, and if it's going to inhibit their ability to come to a standing position safely and be able to engage those hip joints. Then moving forward to that functional assessment, are they able to stand up, pull to stand in the parallel bars with their knees blocked and control their hip extension in the sagittal plane? If I might have done this backwards. So if they are not able to control their hip extension, then you can consider an RGO. Sorry, I'm going to flip those. If they are able to control their hip extension in the sagittal plane, KFOs are probably appropriate. That's outside of the scope of this talk. But assuming that they are not able to control their hip extension, and then withstanding with the prefabricated locked KFOs, they're not able to initiate a step, an RGO would probably be appropriate for them, assuming that they have good control, they have a good understanding of what the RGO is, the time commitment required, and they have an actual goal of reciprocal ambulation. If they don't have that goal in mind, there are other devices that might be appropriate, like locked HKFOs or something else. But if they're all on board and we're moving forward with an RGO, then there's a lot more that needs to be done. So as far as the ideal candidate for an RGO, ideally they wouldn't have any spasticity or it'd be fairly well managed, no contractures, no leg length discrepancy, fairly neutral alignment, and of course be very motivated to use the device because of the amount of time that it requires, the time commitment. But obviously there are lots of things that can be accommodated, and each patient should be evaluated on a case-by-case basis. So we will move on to the timeline section. So I've broken the timeline into 2 different phases. The first phase is everything leading up to the RGO, and the second phase is everything that happens once the device has physically been delivered to the patient. So phase 1 includes pre-RGO physical therapy and the patient's home exercise program, which will continue up until the day of delivery of the device. After a physical therapist identifies that a patient is a potential RGO candidate, they'll be seen for an orthotic evaluation with an orthotist present, and we'll start the insurance authorization process after that point if we determine that the RGO is appropriate. We'll start by we're scheduled to casting within the next week or 2 following the orthotic evaluation, so that by the time the RGO has been approved by the insurance company, the casting has already been completed, and then we can send the cast right out from that day for the fabrication. And fabrication can take a few months. It does take a long time. And then the patient will be seen for multiple fittings. Phase 2 starts at delivery, which I like to do with the physical therapist present, so that the patient can stand for the first time. Then on the physical therapist schedule, the patient will ideally resume or start a bout of care, and the orthotist will follow up periodically throughout that early PT program to make any needed adjustments. And at some point, the patient will start to use the device at home once they've been cleared by their therapist. And of course, at regular intervals, they'll come see us for routine maintenance. Oops. Okay. So phase 1 starts off with pre-RGO physical therapy. Range of motion is really the most important during this time in preparation for the RGO, especially for patients that will be discharged from physical therapy and ending a bout of care and then resuming once they have the RGO. Often I see patients that have been discharged from PT. They come to our office for casting 2 weeks later and they're a little bit tighter, and then they are out of therapy. They're not doing their home stretches, and they come to delivery of the device and they're even tighter. So it's really helpful that a really good thing if the patient is working on their home exercise program if they are going to be discharged from PT in the meantime. Other things that patients can work on in the interim are upper extremity strengthening and some trunk exercises and weight shifting as well to prepare for reciprocal gait. Okay. Once a therapist has identified a patient might be a candidate for an RGO, we do require a prescription from a referring physician prior to scheduling an orthotic evaluation. Even if we end up doing something different than an RGO, or if the patient is initially sent for KFOs and we end up doing an RGO, we can always send a detailed order to the physician after the fact, but we need something to get started. And like I said, evaluating in a multidisciplinary clinic setting is really best so that we can evaluate the patient from all aspects of their care. Typically, I schedule patients for casting while they are at their orthotic evaluation, just so that they have the next appointment on their calendar. They have something to look forward to, and we can really discuss what the expectations are for the process moving forward. Then we can start the insurance authorization process, which can take anywhere from a few days to a few weeks, depending on the funder. The casting appointment is long and very involved. It always requires at least 2 clinicians, sometimes 3. So we require that patients come to our office in Linthicum for casting. I tell patients to plan for 3 hours, and it usually does take the whole time. The reason it takes so long is that we're basically making 3 devices in one. So we're making bilateral KFOs as well as a TLSO or an LSO. So the more accurate the cast, the better fitting the device is going to be in the end. So it's really important to make sure that the measurements and the casts are as accurate as possible so that we can have the best outcomes in the end. Patients should plan to bring shorts to the appointment if they don't mind getting messy, but we do have paper shorts available if patients do not have that on their own. Okay, After casting is complete and we have authorization for the device, we send the cast off to a central fabrication facility. RGOs are incredibly complex, and to my knowledge, there's only one fabricator that actually will make that reciprocal mechanism in the posterior. These are a couple examples of the different styles. So the hooped cables and the isometric rocker bar. But it's very specialized. And because there's only this one company that will do that component, fabrication can take 2 to 3 months for them to actually fabricate, 1 to 2 months for them to fabricate. Usually it's closer to those 10 weeks. So definitely plan a longer period of time for fabrication alone. So really important for the patient to be working with their PT or on their home exercise program while they are waiting for this device. All right. So once we finally have the device back in our office and I've had a chance to actually look over everything to make sure it looks like it's supposed to, we can call the patient to schedule their first diagnostic fitting. Like the casting, this appointment must take place in our office in Linthicum. The reason for that is that we have a full-scale technical lab in the back. We do fabricate a lot of things in-house, not RGOs because of the complexity, but we have all the tools to make most of the modifications that are required. I tell patients to plan for 3 hours. Typically, the first fitting will take those full 3 hours, like the casting. We're basically fitting all 3 devices that we casted for. We're fitting all 3 devices and then putting them together and fitting it as a whole device. So it's a very involved process. Lots of trimming, lots of heating, lots of modifying. So there's a lot of work that needs to be done. Usually I do the fittings in parts. So I will break the device into bilateral KFOs and then fit the trunk section and then put everything back together and fit everything together. Usually 1 diagnostic fitting is required, sometimes 2, roughly 2 to 3 weeks apart, depending on how much modification needs to be done in the meantime. And sometimes in certain circumstances, the device needs to be sent back to the manufacturer for modifications that we can't do. Like the rocker bar that you see in this picture here, that's metal that we are not able to bend at our facility just because of its thickness. So there are some things that we can't do, but any of the plastic modifications, we can do those on site. So the last diagnostic fitting will become the final fitting, whether it's the first or third diagnostic fitting. At this appointment, we make our final modifications to the device, and keep in mind that this is all non-weight bearing fitting at this point. We haven't had the patient stand. So we'll also assess the device in sitting to make sure the patient is able to transition from supine to sitting on the clinical exam table. And then we teach the patient how to operate the orthosis, make sure that they know how to work the hip joints, knee joints, practice donning and doffing. And it's really helpful if a family member is also present so that we can show them how to use it as well. Because once the patient is in the device, it's much more difficult to actually see what's happening. So if we can show somebody else, they can work through it together. We also talk about shoe recommendations as well, because they'll need to get a shoe that's a half to a whole size larger just to accommodate the RGO. So it's really important that the patient knows that this, unless in rare circumstances, the patient is really not going to be standing at our office during this final fitting appointment. The reason we do that is because our office is not really equipped to have somebody stand with this complex of a device initially. So someone that has never used an RGO before, we do have a set of parallel bars here for standing, but most of the other assistive devices that we have here are not really wide enough to accommodate the width of the RGO. And just for safety purposes, we really want to have that physical therapist present that knows it better. In certain circumstances, for pediatric patients or for patients that have already used an RGO, that's a different story. But typically, we want the physical therapist present for that visit for patient safety. So moving on to delivery. So this is the appointment when the patient will actually be able to stand with their device. Typically, I will bring the RGO over to the multidisciplinary clinic for the patient, unless in rare circumstances I've had the conversation with the patient, make sure that they're not going to use the device at home on their own. If I feel like I can trust them to not use the device, I will send it home with them and they can bring it to that appointment. But typically it's easier for me to just transport it for them because of the bulk and the weight of the device. So the word delivery can be a bit confusing to patients, as this doesn't necessarily mean that they are taking the device home with them. They might be, depending on how a certain physical therapy clinic is set up. But typically the RGO won't go home with the patient until they're cleared to do so by the physical therapist. So at this appointment, though, at the delivery appointment, the patient will be able to stand with the device, maybe learn how to weight shift, take a step or two in the parallel bars under supervision of the physical therapist. Not really meant to do full gait training at this point, but the orthotist is present to make some dynamic alignment adjustments. Since this is usually the first time that we're seeing the patient actually stand with the device. Usually that means adding some heel wedges or an arch pad, just looking at weight bearing shifts once the patient is standing in the device. All right. So next stop in phase 2 is RGO training with the physical therapist. So I try to check in after 2 weeks of PT with the RGO just to see how the patient's doing with the device, if there are any other modifications that need to be made. But oftentimes I'll hear from the physical therapist earlier than that with some recommendations for adjustments that need to be made. And during this time, the RGO usually lives with the physical therapist or send it home with the patient with the understanding that they are not going to use it unless they are in physical therapy. And again, this is just for patient safety. Once the patient has been cleared for home use by the physical therapist, the PT and the patient together can come up with what their plan is for their home therapy program, how they're going to use the device in their home environment, what kind of exercises or time frame they'll be using the device for. And then routine maintenance is recommended every 6 months for pediatric patients and 12 months for adults. Typically, the hinges will need to be tightened or lubricated over time. And also the metal components, I think you can see the plate on the top upper right corner where the plate has been warped. That's from a lot of daily, weekly use of the RGO over a couple years. So it's a good idea to have the RGO looked at routinely for maintenance. Of course, if you hear noises or you see cracks, anything like that, please do let us know. Oftentimes you're seeing the patient a lot more frequently than we are, and we don't know there's a problem unless someone tells us. And the strap pops off, something like that. Obviously, we're happy to see the patient in our Linthicum office. We can usually squeeze them in for an emergency appointment if it's something that's like a strap came off of the device. We have an on-call appointment available. But if it's something that requires more assessment, definitely reach out to us and we can get the patient in for a full appointment. And if you see the patient and you feel like something's not quite working the way that it should, please do let us know. We can consult. All right. Last section will be fairly brief here because I don't want to take up all of your time. But I do want to touch a little bit on patient goals and expectations. So even before the orthotic evaluation, it's really important to figure out what a patient's actual goals are for the device. And once we've determined that they're a candidate for the RGO, can the device actually help them meet those goals? In addition, do they have particular goals or desires for the RGO itself? Are there things that they're expecting it will do? And maybe it will, maybe it won't, but we need to talk about those things up front. Some of the goals may include range of motion management, greater independence with their ADLs, independent donning or doffing of the device, dynamic stabilization of their joints or improving their balance, or even alleviating proximal joint pain. So all of these things will help determine what kind of device is appropriate, what kind of componentry to put in the device. These things are really outside of the scope of this lecture, but they're definitely important to consider. So I do want to mention some of the drawbacks of RGOs or challenges. They're really not intuitive devices. They require a lot of training, physical therapy, effort. They can be very dangerous for the patient without proper supervision, which is why we have such strict requirements on where they're going to be standing, just for their safety. We don't want them to fall or get injured because this could really negatively impact their rehabilitation. And the biggest thing is that RGOs require a really large time investment from the patient and everyone involved in their care. From eval to delivery, it's about 5 to 6 months, and then another 3 to 6 months for therapy after they have the device. So that's a 9 to 12 month time commitment from the patient and from the therapist too, because you're working with them. So it's not something to enter into lightheartedly. You want to really think about whether this device is going to be appropriate for them. However, despite all the drawbacks, there are so many great things about RGOs. RGOs can allow individuals with spinal cord injuries to ambulate with an assistive device within their home. Maybe it's something as simple as standing at the sink to wash dishes, or even just standing to hug their loved one. So for the right patient, it is definitely worth every bit of effort that is put in. So thank you to everyone for attending today. I hope it was a helpful introduction to RGOs. If you have any questions, feel free to add them in the chat or unmute, and we can have a discussion. Oh, there's one in the chat.
One chat.
Thank you for coming. I think when is the date of our next Lunch and Learn?
Our next one is March 10th. It'll be with Rob. He will be presenting on prosthetics for partial feet. But we are in the process of getting all of our videos on the website. All the ones that have happened already are there already for you to see. And this one will be up once we have it ready and uploaded to the website. So you can always do a review of it if you wish, or if you wish to share it.
So the question in the chat, can RGOs be appropriate for people with cognitive impairments? That is a really good question. It does depend on the patient. You definitely want to make sure that they're cognitively aware of how the componentry works. So if they're not able to understand that when their knee joints are unlocked, when the hip joints are unlocked, probably not the appropriate device for them. Maybe something more like a locked HKFO may be more appropriate, where someone can actually help them lock the device. But that it is not intuitive, so it can be a challenge, depending on the patient though.
No, that's good. And depending on what your goal is, what your goal and the patient's goal is. So if it really is walking, is it reciprocal walking? Is that really the important part? Or is it just getting up and being able to stand upright and move and that kind of thing? What can you handle?
Yeah. And are they using it in more in an independent capacity with an assistive device, or are they always going to have someone present with them to operate the device? That's a good question. Thanks.
All right, well, I think we'll just let everyone go. Thanks again. If you have any questions, you can always email us at academy@dankmeyer.com or Rochelle directly at rdumm@dankmeyer.com. And we look forward to seeing you at the next one.
Thank you, everyone.